you. This conference has been excellent so far, and so I really want to thank the sponsors and organizers for putting it together. I have to admit that I've already learned quite a few things. Like one, that I'm not supposed to call it hip pain, I should be calling it groin pain. So you'll see some of these updates throughout it so that, just reflecting the knowledge as we continue to evolve and learn what's going on with these hips. Um, so Professor Lunig actually set this up nicely, thinking about this interaction between structure and movement in his response to Andrea's question about why do some people get pain and others don't. And so what I'm going to do is spend this next time talking about this interaction, using a little bit of a biomechanical lens to it. So thinking about load within the joint or around the joint. And I'm going to do it by presenting 3 different case studies. So I'm going to talk about a recreational runner, a lacrosse player, and a soccer goalie. And I think by looking at individual case studies, sometimes that helps us apply some of the evidence and think about, what do I do with this knowledge that I'm gaining? And so let's start with our recreational runner. So she was a 31-year-old female. She had right anterior hip or groin pain. And one of the first things that happens when somebody comes in with pain is they end up with imaging studies. And so if we look at her AP pelvis view here, we measure that center edge angle. So how much of the acetabulum is covering the femur. And for her, it was 18 degrees. Now, in some of the talks, we've already seen that a normal center edge angle would be 25 degrees. So for her, she has right acetabular dysplasia. And so how do I interpret that? I interpret that as decreased bony stability within that hip joint. And one of the other imaging studies that often is done is an MRI or an MRA. And so what we can see on hers is that she has a right acetabular labral tear, or maybe we should call it a lesion, because maybe it's not really a tear. And I agree with that terminology. So we've already heard what the labrum does. So it's there to add stability in multiple different ways and add that suction seal. And so we can interpret this for her when she has that tear as decreased passive tissue stability. So she has decreased stability from 2 different standpoints, from the bony standpoint and then also from the passive tissues around the hip. And so you can think then that for her, the problem must be the anatomy, because that's an anatomical problem. But as a physio, I like to look at what's going on with that person. Here's how she stood. So hopefully, looking at that standing posture, you would not think that that is ideal posture. We also heard yesterday that women with hip pain in their 30s, it's probably because they had babies and aren't very strong and have gotten deconditioned. Well, I will kind of give a little bit to that because I defend the way she stands in that she's had 3 babies in 5 years. So in the past 5 years, she's either been pregnant, holding a newborn, pregnant and holding a newborn, holding a toddler and a newborn, holding a toddler and a newborn, and pregnant. So you can understand that she thought this was normal standing posture because this is how she has to spend her day. So fine, I can understand that, but it's also contributing to her problem. So when we got her to stand up straight, which she felt was falling forward, and have her ears over her hips, over her ankles, that's a much better posture. And because I have a biomechanics lab and can then look at these things and quantify what's going on, we were able to look at the force or load, and we were looking at it in terms of the hip moment, so that force times distance. And for us, we look at internal hip moments, so that's telling me what are the muscles or structures having to do. So when we're talking about that hip flexion moment, we're talking about what are the things at the front of the hip having to do to stabilize her. So in her preferred posture, would not be preferred by me, But her preferred posture, that moment was 20 Newton meters. Now, we don't know if that's too high, too low. All we know is that when we changed that posture, that hip flexion moment came down significantly. So we were reducing how much those anterior structures were having to do. Her pain came down too. But we don't just stand around. We have to be able to walk and do other things. So we told her to apply that same change in posture to her walking posture. And so this is her preferred and then her corrected posture. And, as a biomechanist, I can quantify things. That's great. But as a clinician, what I care about also is what does that do for the patient? And so in that preferred posture, she told me her pain was a 6 out of 10 when she was walking. When we corrected it, it went down to 2 out of a 10. So that's a significant impact for that patient by reducing that pain immediately. It wasn't a change that I had to wait 6 weeks for. It was a change that happened in that one session. So 2 minutes later, her pain is significantly lower while walking than it was before. So we can look at the evidence to try to figure out what was it that she was changing to reduce the pain. And that preferred posture of hers is very similar to a sway back posture, whereas the corrected is a little bit closer to a forward flexed posture, so leaning forward just a little bit. And what the evidence already shows is that when you're in that sway back posture and walking, you end up with greater peak hip extension. You go into more hip extension. And then you also have higher hip flexion moments, so you're requiring more out of those anterior structures. Whereas when we correct that into the forward flexed position, we end up getting into less hip extension and having lower hip flexion moments. So that seems like that's probably what she was doing. But we should always check, is that what the patient did, even though that's the evidence? How do I apply that evidence to this patient? Again, because I'm in a biomechanics lab, I can look at this. So what I'm showing here is our hip extension or her hip angle graphs. So it goes from heel strike when the foot hits the ground, you're in flexion, then as you go through, you go into hip extension, and then your foot hits the ground again in hip flexion again. So those are the curves that I'm showing here. The red is her preferred. When we put the green on top of that, which is our corrected, remember the evidence showed a change in the hip extension angle. We don't really see a change in the hip extension angle, except maybe on the less painful, or non-painful side, the left side. So what happened with her? Well, to do that, to figure that out, if we look at the moment curve, so hip moment, the foot time when my foot hits the ground, I need hip extensors, the hip extensor moment. As I come forward, now I need hip flexors, so those are my hip flexion moment. That's the positive part. It's that hip flexion moment we think is contributing to the problem. So when we look at how that changed, now we do see that decrease. And so that's probably what was happening. That's what she changed in how she was walking. Now we can take it one step farther, because I can look at the joint forces. So how much is that femoral head pressing forward on the acetabulum? And so that's the anterior, the positive joint force. And what we see is that we reduced that as well. So by reducing her hip flexion moment, we also reduced that anterior hip joint force. And by that, significantly reduced her pain. And all of those changes were critical for her because of the structure she had. So we have to put those two together and how they're playing together to think about what do we do for this patient. Now, as Kay highlighted very nicely, we have to ask the patient what is it that their goal is? What do they want to be able to do with this hip? For her, she wanted to return to recreational running. So we had to think about how do I help her get to that? So we gave her cues to shorten her stride because that's going to reduce peak hip extension. We gave her cues to lean forward a little bit more as she ran. None of this leaning back while she was running. Lean forward so that would reduce the hip flexion moment. We also gave her cues to push off more with her foot so that she was getting that propulsion from her ankle instead of constantly pulling forward with her hip. And all of that worked great, I think. She said she was able to run most of the time without pain, except if she ran on a treadmill. Now you can just say, well, fine, don't run on a treadmill. We're in Boston. We have winter, which means snow. And when I say snow, we get significant snow and ice. I don't think I want her running outside on the snow and the ice. That's not going to be great for her. So we have to think about what's going on as she's running on the treadmill that is changing things. So we had her come back into the lab, had her get up on that treadmill and do her run. And I have to be honest with you. She looked great while running on the treadmill. She was doing everything right. She had shortened that stride. She had pushed with her foot. She was leaning forward. And I was thinking, ooh, there's nothing I'm going to be able to do to help her. So we stopped and, she's slowing down that treadmill. And all of a sudden, you see it. She goes from a nice running form to all of a sudden leaning back and these big strides as that treadmill slows down. And you're like, what? I thought we taught you. And what it was happening was because as the treadmill is slowing down, she switched from running to walking very early. The tread's still going faster than she is. So she was just not applying the information. That's an easy fix. We just told her, transition later. So keep jogging on that treadmill until you don't think you can jog anymore. She emailed me the next morning and was like, ran on the treadmill, no pain. So sometimes it's easy to do those things. I do want to highlight that because of her structure, we had to make more changes than we would have to if she had normal structure. We had to take that into consideration. And I also want to highlight that these were movement modifications. These were not activity modifications or eliminations. I didn't tell her she cannot run anymore. I simply told her to change the way she was doing it and to ease back into it. Think about those load principles, about easing back into these things versus not running and then trying to go do a marathon. That wouldn't be smart. But for her, this worked. So if we now look at a lacrosse player, this is a 15-year-old, so she was not in this category of the 30-year-old, woman. She also had right hip or groin pain, and she also had right mild dysplasia. And so you can think two similar structures, they're going to be similar problems. Just like Professor Lunig highlighted it, not every structure is the same, and not everyone's going to need the same treatment. That's true in physical therapy too. So one of the tests that we look at is a single leg squat. So for this test, we have them stand on one leg. We have the non-stance leg behind. They do a nice controlled squat, come back up, put the foot down. Let's watch her do it. I heard some reactions in the audience. We could watch that again. Hopefully what you can see, and I've highlighted it here in red to make it a little bit easier, is that her pelvis actually rotates backwards. So she goes into hip external rotation. Her pelvis also drops, which puts her in hip adduction, and then she has this knee valgus. So let's watch it one more time in case you didn't pick those up the first time. So what does that do given her structure? So she had dysplasia, she had reduced coverage, that low center edge angle. So if we look at that, as that pelvis drops down and drops down and drops down and drops down, you end up making that center edge angle that much smaller. So she goes from being someone with a mild dysplasia to almost acting like it's moderate or severe dysplasia. And when we think of load and what is that happening, so stress is force over area. As that pelvis is dropping down, her surface area for that force is getting smaller. So her stress is going up in that joint. And so of course we could do, well, I can't do it, but Professor Lunig could do a very nice surgery to bring that acetabulum over the femur more. Or, because I'm a physio, I could tell her, just don't let that pelvis drop down. Control that pelvis as you're doing things. That could be the way to do this. So that's what we did. 12 physical therapy visits over 2 months, focusing on neuromuscular control of the trunk, the pelvis, and the lower extremity, and then progressed her back to functional activities. So here's her single leg squat after physical therapy. Hopefully you'll agree that the control on that is improved, and her pelvis is much more level at that end point. So she's changed that movement in order to accommodate the structure that she has. One of the important things to do with this is it can't just be about the exercises that you're doing in the clinic. It has to be about how do they translate that to their daily activities. So we had to convince her that as she's doing her sport, she should be conscious of this movement change as well. And in fact, she was able to return to her sport without surgery and to maintain the improved posture while running in her sport. And so that can make a substantial difference for someone when they're able to translate that change in movement to what they're doing on a daily basis or what they're doing as part of their sport and be able to do it without pain. So now let's move on to the last case. This is our soccer goalie. 16-year-old female athlete, bilateral hip and groin pain. While, maybe CAM is not as severe in females, we definitely see it in females. And we see a lot of hip pain. And truly, when we look at the surgical stats, it seems that women are getting surgery more. About 55% are females. So that makes us wonder what's going on here if they have a lower severity of CAM. And I personally think that it's how they're moving. Obviously, I'm a physio. That's what I focus on. So she had bilateral CAM morphology. And so as we think about the graphics, as you go into different positions like hip flexion, you end up getting impingement. Now, we typically think about that in terms of bringing the femur towards the acetabulum because that's the test, right? The flexion, adduction, internal rotation, femur towards acetabulum. But we also need to be thinking about it from the other direction, that if we're moving the acetabulum forward, so if you're going into anterior pelvic tilt, you also get earlier impingement because you're bringing those bones together. You're going into hip flexion when you anteriorly pelvic tilt. So for her, I'm going to show you a step down. So for our step down, you're on a 16 centimeter step, which is not that high if you ask me. You're told to put one foot out in front of you. We're testing the stance leg. You slowly lower, touch your heel down. You shouldn't be having to push up. It should just be a touch and come back up in a nice controlled fashion. Now I'll tell you, she had just finished her competitive soccer season, so she should be in decent shape. Here's her doing her step down. Maybe if we turn from the side and watch her from the side, it'll be better. I think you can all see there's quite a few things that we'd want to work on in this. And I highlight the worst examples because they're so obvious, and so it's so much easier. So if we look at this, I think we'd agree, she just overall has poor control, right? We see multiple things. We see trunk shift and rotation. We see hip adduction. But we also see increased trunk and hip flexion. And if you think about that with her bone shape, why would she go into more hip flexion if she has this bone shape that would be problematic in more hip flexion? You would think that the movement alteration we would see for someone with this bone shape would be that they'd avoid getting to that end range. She's certainly not avoiding getting to that end range. So maybe part of the reason she's having pain with this bone shape is because she's unable to control that end range. She's relying on the bone for stability instead of using muscle. And so you could just say, well, everybody doing a step down task like this is going to go into that much hip flexion. That's just the natural movement. So let's look at a control doing this. So that's what this is supposed to look like. Yeah, I don't see much trunk flexion there. I'm not seeing anterior pelvic tilts. I'm seeing a nice controlled movement. And of course, you could say, this is just this one patient. So we looked at 20 patients with FAIS divided between males and females and compared them to 40 healthy controls. And this study was recently published in JOSPT, so you can see it there. What we found is that those with FAIS go into more hip flexion. And we wanted to know, where is this hip flexion coming from? Is it thigh coming towards hip? No, it's more that the pelvis, they're going into more anterior pelvic tilt or trunk flexion. And that's what's contributing to this problem. And so if we think about that and think about what can we do about that, that's a control problem. That's just about addressing those things. So I do want to highlight one other thing with this example. One of the tests that has been talked about is that deep squat for individuals with FAIS, and whether it's pain or not. But I also think we use that test to look at movement control. So I want to show you her bilateral squat. It's not great. I fully admit that. But it's not horrible. So maybe that's because the other leg was stronger. So if we look at her single leg squat from the other side, maybe that's better. Oh, that's not very good either, is it? All right, maybe it's that other side. Maybe I just had my sides wrong. Yeah, I didn't have my sides wrong. Maybe if I put them together, that'll be better. She could get a lot lower with the bilateral squat. She has better control with the bilateral squat. What's happening? Why is there this difference? And what it is that obviously unilateral is harder than bilateral. It's a higher demand. You're on one leg. But the other part of it that's really important, I think, is that when you're on one leg, you need to control frontal and transverse plane. When you're on two, it's more about sagittal. And so that increased challenge of control is what drives this trunk shift that we're seeing, the pelvic shift, the pelvic drop, the femoral adduction, the knee valgus. So it's so important that we test both unilateral and bilateral activities to really get at what are the functional impairments for this patient in front of me right now. And one of the other things I want to highlight is, while this is a beautiful image, when we show these images of impingement to patients, we sometimes can get this nocebo effect, this negative effect, where when they've seen this image, every time they get pain, they're visualizing this image of red, bad, horrible impingement. It must be breaking my joint. That's not really the effect we want to have. So maybe we need to be careful about what we're saying and what we're showing, because we can be causing harm by our words and our images. And so just say, well, we don't know entirely what's happening, but maybe staying out of this position would be good. Maybe doing it this other way would be better. And so we really need to be conscious of that nocebo effect, the opposite of the placebo effect. And so for her, physical therapy to address strength deficits and control deficits. Sometimes it's not just a strength problem. Sometimes it's the combination. And, it took a while, but she was able to return to her sport with improved movement and without pain and without surgery. So hopefully what I've been able to do through these 3 case studies, through the recreational runner, the lacrosse player, and the goalie, is to really highlight this interaction of structure and movement, and really highlight also this idea that small changes can have big impacts for our patients. And we need to keep that in mind as physios. It's not all about the structure, but maybe it's that interaction between the structure and the movement in that patient. And with that, I'd like to acknowledge my mentors and my collaborators, and also some of my funders, and to thank you for your attention.